Good afternoon, everyone. It's a pleasure to be here and present my one-year PhD progress. My name is Edina Tari, and I'm a first-year PhD student and a first-year gastroenterology resident. My supervisor is Bálint Erős, and my SMS is Anna Trans. My vision is to improve patient care in acute gastrointestinal diseases, and my mission is to conduct high-quality researches in the same topic. So today I would like to present you two of my ongoing projects. My first project is how the morphology of the major papilla affect bile cannulation outcomes and adverse events, which is a systematic review and meta-analysis. So let me talk a little bit about the background. ERCP is the most common therapeutic procedure for pancreatobiliary disorders. However, how to best achieve a safe and effective bile cannulation is still a debated question. ERCP is doing these procedures routinely, often recognize the difference in the macroscopic appearance of the major papilla. This has led to a conclusion that certain appearances are more difficult to cannulate and therefore may be more prone to adverse events. The first validated classification of the morphological appearance of the papilla was published by Haraldson et al. In 2019. They differentiated for papilla types, and they found that certain types were more difficult to cannulate, and in these types the incidence of adverse events were higher. Our aim was to determine that how the morphology of the major papilla influences the ERCP outcomes and adverse events. So our clinical question was that how does the morphology of the major papilla affect bile cannulation outcomes and adverse events, and we used the COCO-POP framework for our project. Our conditions were difficult cannulation, cannulation failure, the number of cannulation attempts and cannulation times, and the incidence of the different adverse events, for example, the incidence of post-ERCP pancreatitis in the context of the morphology of the major papilla in adult patients undergoing ERCP with a native papilla. And our hypotheses were that certain morphologies of the papilla can predict a more difficult cannulation and therefore a higher rate of adverse events. So we conducted our systematic search in 3 databases at the end of September with the following search key, and we could identify almost 7,000 articles, and from that 36 were eligible for full text selection, and in the end we could include 17 articles to our systematic review and 13 articles to the meta-analytical calculations. And here you can see my outcomes. For the outcome measured, we use pooled event rate, and the meta-analytical calculation were possible in case of 4 outcomes, and the other 4 outcomes could went to the systematic review part. And I would like to show you today 2 of my forest plot. In the first forest plot, you can see the pooled event rate of difficult cannulation. In the forest plot below each other, you can see the pooled event rate of difficult cannulation in the different 4 papilla types. We think that this question is important because the more difficult the cannulation, the higher the chance for developing the different adverse events. And you can say that in this case the heterogeneity was high. It could be due to the fact that most studies use the ESGA definition for difficult cannulation. However, there were some studies which used a little bit different definition to define difficult cannulation. And I think the main message of this plot is that in type 1 papilla, compared to the other papilla types, the rate of difficult cannulation was lower. These results were not statistically significant. However, the p-value refers for a higher tendency for difficult cannulation in some papilla types. And it could mean that in the clinical practice, the fellow endoscopists should start their practice with type 1 papilla. In the other forest plot, you can see the pooled event rate of post-ERCP pancreatitis. The building of the forest plot is the same, and in this case, total homogeneity was observed. And the main message of the forest plot is that in type 2 papilla, the pooled event rate of post-ERCP pancreatitis was statistically and significantly higher compared to the other papilla types, which means that these patients should be followed up more carefully carefully for post-ERCP pancreatitis after the procedure. And there were many strengths of our study. For example, it was a comprehensive review with a rigorous methodology, and most studies carried a low risk of bias, and no publication bias was detected. However, there were some limitations. For example, as I mentioned, there were some difference in the clinical definition, and because we included only observational studies, some of them being retrospective, the certainty of evidence was low or very low. So in conclusion, we can say that differentiating between the papilla types is clinically relevant because certain morphologies can predict a higher rate of difficult cannulation or a higher rate of adverse events. And currently, my manuscript is submitted to the American Journal of Gastroenterology. We hope that it will be expected. And very briefly, I would like to talk about my second project, which is about the early resuscitation of the hemodynamically unstable patients with acute gastrointestinal bleeding. This project has two parts. The first part is a protocol for an RCT, and the second part is the feasibility trial of the RCT. So acute gastrointestinal bleeding is a potentially life-threatening event, often requiring ICU care. 1 in 4 patients will develop hemodynamic instability associated with higher rebleeding and mortality rate. However, the recommendations in the guideline about these patients' early care is insufficient. We conducted a systematic search in October last year to identify studies about vasopressor use in this population, and we could identify only one RCT. They included acute gastrointestinal patients in the state of shock requiring ICU care, and they randomized the 51 patients. And in the study arm, the patients received the limited fluid resuscitation combined with vasopressor use, and in the control arm, the patients received the normal conventional fluid resuscitation therapy. And they found that the resuscitation time was lower in the study arm in patients who received limited fluid resuscitation combined with vasopressor. And our plan is to conduct an open-label 2-arm RCT with a superiority study design. Our PICO will be like this. We would like to include patients in the state of hemodynamic instability with acute gastrointestinal bleeding, and the patients will receive in the study arm a combined fluid resuscitation with vasopressor compared to the standard resuscitation therapy, and our primary outcome will be the resuscitation time. And for the feasibility study, we would like to include tandem patients to both arms. So in summary, my first project is currently submitted to the American Journal of Gastroenterology, and for the second project, the study protocol is written, and we are waiting for the ethical approval to start the study. Thank you for your attention.
You mentioned that this morphological classification was from 2019?
Yeah, 2019.
There was none before, so it was just the papilla?
That was the first validated classification. There were some studies which used some kind of classification, but these studies were individual studies with individual classification. After this classification, there were other studies published later using that classification, the Haraldsson one.
And did you ever, I mean now it's maybe too late, but did you ever thought of seeing if the different classifications from before could be used for your study now?
Yeah, we included all type of classification systems. So we conducted meta-analytical calculation with only studies using the Haraldsson classification, and also with other classification systems which were comparable to the Haraldsson one.
May I ask you? Excellent presentation. I would like to ask regarding the second topic. The patients with portal hypertension and variceal bleeding are very specific subgroup of GI bleeders. especially regarding the therapy they are receiving vasoactive treatment with remdesivir right from the beginning, so terlipressin. So are you going to include this patient, exclude, or how are you going to deal with them?
We plan to include these patients for the feasibility study, and after that we will see, maybe they will be excluded for the big trial. We will see after the feasibility trial.
Congratulations on your hard work. I just, right now I was thinking, like you showed that, for example, post-ERCP pancreatitis was more often in type 2, even though it was not with the highest difficult cannulation rate. What's your idea behind that? What might be the reason?
Actually, we discussed it in the discussion part. There are like no specific clinical reason behind that. There were like some idea that maybe the rescue cannulation technique was different between the different papilla types. So maybe that's the reason behind it, but we are not sure.
Thank you.
Also, it would be interesting to see what type of preventive measures were applied to prevent post-ERCP pancreatitis, and the other importance of this study, whether you can make any specific recommendation of different types of papilla, which type of advanced cannulation method should be chosen as the first strategy after the initial cannulation phase, and or just go directly to advanced cannulation method if you are seeing some type of papilla. Could you make any recommendation in your discussion in that submitted article?
There were like some, in most studies, the needle line fistulotomy was the most used in type 2 papilla, and so maybe that was the reason for the difference, but we discussed it, and we plan to later see it on our work too, first retrospectively and then prospectively.
So for the preventive measures, can you make any comparisons or any analysis of the retrieved data?
They didn't discuss the preventive measure for post-ERCP pancreatitis in the different studies, so no. That's one of our limitations.
I have one more question. Is papilla type permanent, or does it change in a patient, for example, a few years later? Or is something preset or genetic? Or
as far as I know, I think it's genetic, so it doesn't change.
I have one more question. I never knew about this morphology difference in papilla shape. Are they associated with any other condition, or are they used beyond the ERCP risk stratification, or do they have any other clinical use?
So this classification was only published kind of recently. So now I think it's mostly used for that to assess safety and the efficacy of ERCP.